first-year pharmacy residents, we have second-year pharmacy residents, we have clinical pharmacists, we have clinical coordinators, supervisors, managers, et cetera. And so members of your preceptor team could be essentially anyone in that group that I just discussed. So your primary preceptor could be a PGY1 resident, and they would then be working with the preceptor of record, who would be the individual that you would find that you're assigned to at core. But you will, over the course of your time here with us, interface a lot with our residents, whether they're first year or second year residents, with our clinical pharmacists, and our other members of the clinical team. Again, using every member of the team to the fullest capacity of their license. So for medication histories, discharge education, students, first-year residents tackle those tasks. Second-year residents do a little more oversight of the first-year residents and the students. The clinical pharmacists or the coordinators have the responsibility for those people under the particular layer. So you may see that you have a preceptor of record who's in core right now, but as it gets closer to that rotation, we may reassign to a different member of the team. For instance, right now for cardiology rotation, Steve Dunn is assigned everybody. He's obviously not going to precept all 14 people who are assigned to a cardiology rotation, and therefore we're going to, over the course of the year, perhaps for rotation 6, reassign to Maury Roth. There's someone going in the classroom. Can we shut that door? I don't know what he's doing. Sorry, I was distracted. And so, it could be Mary or Emily or, any other member of the team. The resident, the cardiology resident whose name is Melissa, she could be one of the preceptors in the second part of the year. So I would encourage you to get to know every member of the team, work with everybody, realize everyone has a role in your education and the delivery of your education. And we're all, again, working to the highest capacity of our licenses to do the most that we can for our patients. And so this model allows us to really extend ourselves in a much greater capacity than if we just had one person doing everything. Are there any questions about the layered learning model? All right. Also, there's a really great article. There are lots of articles, but there's a really great summary that's in Hospital Pharmacy that I'll send that you guys can all look at in advance. All right, I'm going to turn it over to Kristen and Tyler.
I guess for the people in Richmond who don't know who I am, my name's Kristen. I am a PGY1 pharmacy resident.
Hi, I'm Tyler. I'm a PGY1 pharmacy resident. I'll be staying on next year for the second year admin residency.
And I'll be going to Ohio State for my PGY2 in oncology. Exciting. I've prepared just a short slide set so we're going to do 2 sessions. The first one today, we have like an hour blocked out. I don't foresee it taking a full hour, but if we have a lot of questions and stuff like that, we do have the time. But the first one is basically our APPE Bootcamp, and so it's basically just to outline like what to expect for your APPE rotations, how to prepare for them, and just how to be successful. And then the one on Friday, we'll like open up a test patient in Epic, and I'll basically just go through like, this is how I set up my Epic, this is like the tabs that I use, this is how I work up my patients. So I think that that'll be really helpful for you guys, just to maybe everyone kind of adapts their own style of doing it, but seeing how at least one person does it before you have to do it yourself is very helpful. And then I guess just to talk about, so Michelle just talked about the layered learning. It's a very interesting, like it is a model that I had encountered like all throughout the year. And it's actually really, really like interesting and helpful. And so like for me at the beginning of the year, when I had a student, it was more like me and the student working with our preceptors. So it wasn't necessarily like I was taking on the most active role because I just became a pharmacist like 2 months before that. And so, but towards the end of rotation, I was having the student present the patients to me, and then as a group, we would present the patients to the pharmacist after round. So it was a very low-key way to kind of dip your toes into precepting and that layered learning model. So
yeah, and I would say it's beneficial for the student and the resident alike. So the resident has a fresh perspective on being a student for your first year out. So there are things that the preceptors haven't experienced in a couple of years that we know is really important as a student, things that you need to be oriented to in the service. So I think that's really beneficial for the student's perspective from the resident. Like Kristen said, you get precepting experience, you also get feedback and the chance to give feedback, which are 2 very valuable experiences.
At the beginning of the year, I had developed a way to work up a patient even as a student, and I noticed that changed as well. And so I really, my first rotation was internal medicine, so I worked with Jillian McClarkey, who I think some of you guys might be familiar with. And the first day, I just asked her up front, I was like, how do you work up your patients? Because I think a lot of times we can go down rabbit holes and get stuck in the endocrinology note that talks about giving them Lantus BID and how we never do Lantus BID. But I think asking your preceptor up front, like how they work up their patients, is always really, really helpful. Yay. Seeing what monitoring forms, sometimes your preceptors have monitoring forms that they use like back in residency that they can forward to you. I know for me the easiest way was to just use an electronic, like we used our like handoff on the side, so that's the way I work up a patient. But sometimes if you have a student, a resident, and a pharmacist all using that handoff, it can get a little busy because only one person can be in it at once. So sometimes for the students, they would have them use like those paper monitoring forms to like work up patients. I know when I had a student on rotation with me, I had her sit down with me and like watch me work up a patient, and so that way she knew how to do it later on. I'm trying to think of what other strategies I use at the beginning of the year.
Yeah, I think definitely as a student, I would say it's really valuable to use the paper form because it's broken into sections and your preceptor can send you one. But it teaches you how to go through the medical chart, pick out the pertinent information, and then how to present that in a succinct manner to your preceptor. So I think I use that as a student. Even my first couple of rotations as a resident, I still use that form because they're really helpful. And every time you go to a new rotation, you're going to be looking at a little bit different things. In a D rotation, you're going to look more into the patient history and what bugs and drugs they've gotten in the past. Where in an ICU, you're going to be more surface level in certain things and more in depth with others. So I think it's valuable to use that form and then adapt it to what you want to look for as you get comfortable looking through charts and develop your own style, change your monitoring form for the rotation and the patient population that you have. And then you'll learn to take on more patients and be able to handle more of a service as it goes through.
So my slides are up. So I just made this. It's only like about 6 or 7 slides, so just to organize the way we think. He's not.
Chris is being projected right now.
I will let it go. So what I wanted to break it down, like before the rotation, at the beginning of the rotation, during rotation, and at the end of rotation. And so before the rotation starts, I don't know, at my old institution we had a specific format for how. Okay, so yeah, ours was about 4 to 6 weeks early. So for you guys, you need to reach out to your preceptor at least 4 weeks early via email, I'm assuming. And so these were the topics that I always inquired about in my email, and maybe you guys have additional ones. But always ask about what you need to review, guidelines, if there's anything that's institutional specific or any of their policies. And so in terms of guidelines, if you're on, say you're going on to like an oncology rotation, do you know what guidelines you'd want to review? That's good. So like the NCCN guidelines would be what you would use for that. If you're going on to some sort of cardiology or even benign heme rotation, which some of you may have, the chest guidelines are really good. Okay, she's off now. There's guidelines called the ASH guidelines, which I had never heard of, and they're really good. And then there's also articles called, if you like search how do I treat, they come up with really good hematology articles. If you're on an infectious disease rotation, do you know what kind of guidelines you reference for those? IDSA, yeah. So the IDSA guidelines. I'm trying to think of
Oncology. Another thing to add to this is, I don't know if you guys are familiar with using Google Drives or some other Dropbox, but as you pull in guidelines, save them, because you'll bring them up continuously on your rotations, especially like IDSA and things like that. And you can even share them between yourselves. I think that's really helpful.
And going off the Google Drive is something that I'm starting to adapt finally, and I wish I had done it earlier, because I feel like sometimes you just kind of go in circles, like 6 months ago I had a topic discussion about this, now let me go find my article that I already made like my little topic discussion handout. So if you have it all in one place, it makes it so much easier to then not have to run the wheel again. ask what you need to bring. So some places, I know here, you'll be provided with your Surface Pro. But sometimes even I know on rounds, I would always have like a tiny little notebook that I would keep in my pocket because, I don't know, sometimes I wouldn't always have my laptop handy or it would crash during rounds, and it was nice to always have a little something else to write on. There are these like little, what's my favorite word? I don't know, these little tiny notebooks that are basically line paper that you can just use too. I don't know if you adapted any other things that you brought with you.
No, if you have an iPad or something like that.
Hi, it's Dr. McCarthy here. Actually, everyone who will be doing rotations here in the inpatient setting will, for their rotations, be able to use a tablet provided by the department so that you can access APPE. And for instance, if you are here for 3 rotations in a row that are in the inpatient setting, you can take the tablet for 15 weeks and then turn it back into me at the end of the last day. And then perhaps you go to Martha Jeff for 2 rotations and then you come back here, you can check it back out. So the only rotations here where you won't have access to the tablet would be at the transitional care hospital, at student health, but I've counted up how many people are where, and I have all the tablets that I need for every student on rotation here for the inpatient specific rotations, which will allow you to get EPIC and not have to like encrypt your own device.
No EPIC, no tablets for AmCare here, or do they get one for?
Yeah, if you're like with Dr. Goldman in the cardiology clinic, or Dr. Delk in the geriatrics clinic, I know someone's doing that rotation, or Dr. White, you will have access to a tablet then too. Yeah, it's everywhere, but student health, maybe the ambulatory pharmacy and the transitional care hospital. Oh, and Health South and Compass Health, like the outpatient pharmacy. I don't know that I added that in my count because unless you're going to do like discharge education and you need a tablet, and then in that case I'll like redo my count to make sure I've included everybody.
Taylor, one of the other residents, talked about the little pocket guidebook from UNC. Do you guys know more about that? I couldn't find it online at all. We like searched exhaustively.
Gotcha.
Can you talk about that?
So they come out with that every year and they update it. I bought 2 of them last year, so I'll look back and see where I bought it from and try to send you that link. Yeah, send me an email after this and send a reminder, and I'll send you the link. But yeah, that was really helpful because it goes through disease states and then any big guideline things. So that's a really helpful guide.
Should also definitely be upfront and ask where you need to meet your preceptor on the first day, because there are oftentimes times when the preceptor is already up on the floor rounding and you should just know to go up on the floor. So always ask where you should meet. If they want to meet before rounds, this is just like even on a daily basis too, because sometimes I know, especially on my internal medicine rotation, they'd always like to chat about patients about 30 minutes even before rounds started. So knowing what your timeline looks like in the morning to make sure that you've got enough time. I put ask about the dress code. It should be understandable that you know to dress professionally, but sometimes you can always ask. Some rotations you aren't necessarily required to bring your white coat, or I don't think you'll be wearing scrubs for any of your rotations. Oh, the ED.
ED and the overnight rotation, the clinical overnight rotation will be scrub dress code.
Okay.
And yeah, I would say definitely bring your white coat on the first day and the first week until your preceptor tells you that you won't be needing or that you won't be wearing it. I would just show up with it.
White coats are the best for rounds because you can just stuff your pockets. You can stuff them with your little pocket guides, with your patient list, with snacks and pens and stuff like that. So
especially if you have a tablet.
I would definitely encourage the white coat. And then I always ask if there are any specific rotation considerations. So I know here parking, I think, is done on day 1 in the afternoon. But I know for even where I was at previously, like you sometimes need specific badge access for certain things and stuff like that. So I don't know if Dr. McCarthy wants to chime in.
Me again. So for anyone who's coming here for your first rotation here, you will have a little bit of a different workflow than any subsequent rotation here. So if you are going to do 2 rotations in Richmond and then you're going to show up here for block 3, you will have some onboarding that you have to do before that first rotation here. So another piece of data to give your preceptor when you reach out to them is, this is my first UVA rotation. or this is my 5th UVA rotation. If it is your 5th UVA rotation, you literally just need to know where and when to meet the preceptor on day 1. But the first day of your first rotation here, there is a little bit of a different workflow because we do have to allocate time to go get a badge. And the badge office isn't open until 8:30. And then we have some general orientation that we do before we send you off to meet with your preceptor. So add that into your conversation with your preceptor, what rotation you are at UVA. So again, first, or you could just say, again, if it's like block 7 and it's your 5th rotation at UVA, you could just say, I've had previous rotations at UVA, and then that will make sure that the preceptor is giving you the information they need. Everybody will have a number of modules that they have to do to onboard in advance of the rotation, and you would receive communication about that from our education and media specialist, Chris Toby. So if he reaches out and asks you for your date of birth and your social security number, you need to provide that to him in a timely fashion because we've got to run it through security and then get you onboarded into the modules. And so there is a fair amount of rotation pre-work. I would say around 12 to 14 hours for the before your first rotation here. But then you'll never have to do that work again after you do it the first time.
Another thing that Dr. McCarthy just reminded me of is when you reach out, if you're having any days off, like this is big around mid-year time, be upfront and that is in as advanced as possible, as much in advance as possible, so they can be prepared for that and they know when you're going to be off and they can help create your rotation schedule when they do that.
I'm gonna say it's okay to take the time. Like you shouldn't be hesitant to go to these meetings because you're going to be missing rotation, but you also need to be very upfront with them because a lot of times they'll send you like a calendar after you send your initial email, and that'll help them craft your calendar better.
Just remember there are School of Pharmacy procedures regarding requesting days off for meetings, so just be sure you follow those.
Do you have a question?
I was just going to ask, so whatever Dr. McCarthy said, does that also pertain to UVA students like here? Us?
No, I already told you. Okay. That's what I would, yeah.
Any other things that you think you should include in your email before?
I think that's a long email.
Yeah, it's a little wordy, but then luckily for future ones, I would just always kind of copy forward my thing and be like, and I've completed rotations in X, Y, Z, just so they can see like your progression. So at the beginning of the rotation, make a list of goals you want to accomplish, and this is twofold. So a lot of times the first day of your rotation, your preceptor will ask you, so what are your goals for rotation? So having them crafted beforehand will help the awkward silence of you trying to think of what you want to accomplish. And then it also helps them cater their rotation to like what you want. And so I think that that's always really important because sometimes you'll get to the end of the rotation and you'll like your feedback will be like, you know, I really wish I would have done X, Y, Z, but that was never a goal communicated at the beginning of the rotation. So I think really craft your goals to like what you personally want to accomplish, and then always ask the preceptor for their expectations for the rotation. So being upfront at the beginning, knowing what projects you need to complete, whether it's a case presentation, a journal club, the expectation for the number of patients they want you to follow. I think at the beginning as a student, I wanted to try and own the whole service, and that is not necessarily very realistic. So I know, especially on my internal med rotation, when we had a student, they basically said you would do one patient for every week you were on rotation. So your first week, you're really just following one patient. Second week, you pick up to 2. Third week, you pick up to 3. And then depending on your workload and stuff like that, if they think that you can take on more, they would assign you more. And then also see if the preceptor wants you to present the patients to them in the morning, and like if so, what kind of style that they would like it in. Do they want a problem list? If you're in the ICU list, sometimes it's by system, so cardiovascular, GI, endo, and stuff like that. So just be clear, and it's always helpful to know that if you have to present a patient ahead of time.
And yeah, especially with goals. So I would say it's important to keep them on your long-term goals. So if you want to be a resident the next year, definitely be upfront about that with your preceptor because there are different projects they can involve you in throughout the rotation. They can really help you speak to those in interviews and put on your CV. For instance, I knew I wanted to do administration, so they involved me in operationalizing different medications, like switching from one to another. And getting those loaded in Pixis and things like that. And those are things that I was able to speak to and things that I actually got to own as a student. So if you're upfront about those, you can communicate those and they can help you work towards those.
And I think knowing too, a lot of times for even my PGY1, I had to do case presentations for certain places that I was interviewing at. So having done, I asked to do multiple presentations during the beginning half of my year, not so much towards the end, but it was helpful to have multiple different case presentations to pick from when I went to interview. So when you're very highly motivated at the beginning of the year, it's definitely the time to take on a lot of these projects. In terms of expectations, some preceptors might expect you to do a med rec, which I'm sure that you are all very familiar with how to do, but there are going to be, I think, modules that you'd have to go through to complete to learn how to do one for at UVA specifically. Discharge counseling is something that you guys will also be heavily involved in during your inpatient rotations. And so I always liked at the beginning of the year to kind of say to my preceptor, hey, this is the medications the patient's leaving on. These are my main counseling points. Is there anything I'm missing and stuff like that? So just being clear with that. And then topic discussions are another big part of your rotations. And so a lot of times your preceptors will provide you with readings. If they give you a reading, it's not you should always read the reading. It's not just like they're trying to give you something just to take up your time. Always read their readings and then see if they need specific handouts. Because I know on some rotations I was at, they liked actually a paper handout of what the topic discussion was going to be about, kind of my highlights of the articles, versus others were more just like round robin style, and we would just talk about the articles. So.
But yeah, that just goes back to what Kristen was saying about just clarifying expectations when you have a topic discussion. Before the first one, like, do I need to have a handout? And just ask them how they want the topic discussion to go. Some of them, especially towards the end, are going to want you to kind of take the lead on these and talk through the article basically as you're teaching the preceptor the content, and then they'll kind of fill in the gaps. So definitely clarify beforehand if they want a handout or what they want you to do.
I would just like to add that if you have scheduled topic discussions, definitely days in advance of those, you want to get the information about what you need to do to be prepared. Like an hour before, it's not cool.
Right,
Yeah, because you're not going to be able to be prepared an hour before. So you want to get the expectations clarified at the beginning so that you know what you need to do to be prepared. Also, again, thinking about beginning of rotation conversation. So when Tyler was talking about being residency bound, if you are residency bound, you are going to need letters of recommendation from preceptors, likely. And is that another slide? Okay, sorry.
No.
We'll just let Kristen talk about that in a bit.
Don't worry, I didn't forget that. But yeah, so that's all stuff that will go on at the beginning of rotation. During rotation, always ask for feedback. And feedback can be given during rotation both like formally as well as informally. So a lot of times, even like throughout the day, your preceptor will give you feedback on, hey, if I were you, next time I would look at this while you're working up your patients for tomorrow. And then midway through your rotation, you'll typically have like a formal sit down. This is how you're doing halfway through. This is what you need to do to improve. And so the biggest thing for this is if you're given feedback, incorporate the feedback. Don't just nod your head and keep doing things the same way, because you're just going to keep getting the same feedback. Like, Kristen needs to improve how she does X, Y, Z every time. And so I think that really shows personal growth for the preceptors too, when you're actually able to take what they say and change how you practice.
Yeah. And I would say for residency interviews and job interviews, two of the biggest things that employers look for are how do you take feedback, and then how do you correct an action when you get feedback. So those are great examples. And interviewer asks you, like, how do you take feedback? Well, I had this example from rotation when my preceptor told me this, and this is what I did about it. So those are just great things to keep in mind.
So for all potentially residency bound candidates, that is definitely a question. Even this year when I was going through it, was tell me about, and then going forward to it, like, you have to know how to give feedback to students as well too. So treat each rotation like it's a job interview. Don't burn bridges on rotation. You never know if these might be your future preceptors, your future colleagues. I've had multiple colleagues in pharmacy school think they were going to go one trajectory, ended up going another, and used all their contacts from their APPE rotations as potential references. So don't burn bridges. And then always seek out additional opportunities. And so this just kind of shows you taking initiative. If there was an interesting case, like patient, and you wanted to do a particular case report, if you're in the ED and you want to shadow the toxicologist, if there's anything that you want to do that, you know, would help enhance your rotation, always seek out those opportunities. The worst thing a preceptor can say is no, or you have too much on your plate right now, maybe later on. But I think it's always good to take initiative. I know for me personally, seeking out research was something that I was able to do through my rotation because it was something that I didn't have experience with before. So never hurts to ask, and sometimes they might not have things for you right then and there, but if something ever comes up, they know that you're interested in following up with that.
I wanted to chime in on the feedback. So not every conversation about feedback will start with this is feedback, but really feedback is what you should start doing that you're not currently doing, what you should stop doing, or what you should keep doing. So if someone gives you start doing, stop doing, or keep doing, that is feedback, even if they didn't start the conversation with this as feedback. But, you know, at the end of the day, you could even get together with your preceptor and think through some situations that happened that day, and you start the conversation and say, well, when I was thinking back to rounds and when I suggested X, Y, Z, and the team didn't go for it, like what suggestions do you have for me to get my recommendations accepted in the future? Like think about the kinds of questions that you can ask so you can start doing things differently. You can stop doing the things that aren't going to work, and then the things you need to keep doing. So you are more than welcome to start that conversation.
And a lot of times it is like personal reflection too. Sometimes your more formal feedback sessions will start with, well, how do you think you're doing? And so you have to be able to reflect on your current experience too. So some useful resource, don't worry, I'm getting to the letters of recommendation at the very end, but some useful resources during rotation. So I just, in all caps, wrote never reference class notes as your primary source. I think class notes are excellent to maybe, like, at the beginning of rotation, get a quick refresher. I did it on my second rotation as a student, and I was like, well, in my lecture, they did this, and she was like, Kristen, what did you just say? And I was like, in my lecture, I had these notes, and she was like, that's completely incorrect. So don't ever reference your class notes. Use them as something that you can just look at, but never always go back to, like, the guidelines when you're actually referencing things. LexiComp is something that we have access to here at UVA. GoodRx, the app is good to download on your phone, especially if you're on like an internal med rotation where you're going to be discharging patients who might not have insurance, might not be covered through our prescription drug program. So being able to quick pull up on rounds how much a drug will cost is helpful. UpToDate is also very helpful if you have a patient presenting with a random disease state that you're not super familiar with. This gives you a nice high-level overview of everything. ASCVD risk calculator, there's an app that you can download for that. I'm not sure if you guys all have that, but especially on rotation, they'll always want to know their ASCVD risk score. Credible Meds is useful for finding if a patient's on multiple QT prolonging meds. The Sanford Guide, I would highly, highly recommend. So I downloaded this app this year for residency, and it saved my life. It's called the Sanford Guide, and it's $6.99. It's worth it. You can if your patient has any type of bug or you're starting on any type of drug, say they have bacterial meningitis and they're less than 2 years old, you could type that in on this phone, and not on this particular phone, but on the app, and it'll spit out like what antibiotics they should be on and stuff like that, the doses and everything. So it's actually really, really helpful, and I got this from one of my colleagues that I worked with on the weekend, so that was helpful. Have you guys ever heard of the Journal Club app? Another really useful app. I think it's $3, but any major clinical trial that's ever come up, like so say the Hokusai trial was really big for the DOACs in cancer patients, it basically summarizes clinical trials for you. This isn't in replacement of doing a journal club, so this could be a good reference for you, but it's really, really helpful if on rounds they reference the rabbit trial and you just want to know quick details about a clinical trial.
Yeah, but these are great places to start when looking up information. So for UpToDate, it's a great place to get a disease state overview. And then they all get their information from primary sources. So they have those sources listed at the bottom. So I would recommend starting with these, getting kind of your feet under you, and then diving into more primary literature and then use that primary literature that you look at as reference in your presentations and when you're talking to your preceptor.
Do you use any other apps or anything?
That's a pretty good list. I know LexiComp you guys get through the school, I think. So I would definitely take advantage of the ones you get for free. Other than the Stanford Guide one is really good. I didn't pay for any of those.
Just our suggestion is if you go to look something up on your phone, you probably want to say to your preceptor, I'm going to look that up on my phone.
Yeah.
Because otherwise the assumption may be that you're not using that phone for work-related purpose. So just scripting yourself and that I'm going to look that up, and then you pull your phone out. I'm going to look that up, so that it's not perceived that you're texting or Snapchatting or whatever you young people do.
Yeah, that's a good piece of advice.
And then on rounds, there's always things that come up that you want to look up, and so I would just read the situation, and really you should be writing things down to look up later and be paying attention to everything that the team is talking about so that you can reference that later. And then just go take after rounds, take some time. You'll get time for your preceptor to look more into that, and you guys can talk about it later. But definitely be engaged in rounds.
So in terms of presentations, I put here try and give as many presentations as you can to as many different audiences. And so it's obviously you're not going to be giving a PowerPoint presentation to a patient, but the presentation to the patient is more their meds and the side effects. But medical students, physicians, NPs, RNs, and other pharmacists. And when you do these kind of presentations, it's always, and you include them on your CV, it's always helpful to include them presented to a class of 120 pharmacy students, just so that way when people are reading through your CV, they know exactly who the audience was and how many people you were able to present to. Always clarify the length or duration of each presentation, and so, sometimes you might only have 20 minutes and you have 65 slides, and so that would be like an unrealistic length for that. I think it's always helpful to submit a rough draft if time allows, and so that's kind of coming from the expectation from your talk at the beginning with the preceptor, like, on what date do you want me to present? Okay, I'll have my slides to you 7 days before that presentation is due, or 3 days, or however many days you have, just to get their feedback, because that way you can make changes to hopefully improve your presentation. And then, again, always ask for feedback.
Yeah, and as a student, most likely you'll have a journal club and one formal presentation to do. So there should never really be a time where you can't submit it at least a week ahead of time to get some feedback. And then the other big thing is just to practice the night before. That's how you get your timing down and figure out what you want to say. And definitely saying it out loud or practicing with a friend are always just good presentation skills in general. Yeah.
I'm actually presenting to you guys tomorrow.
You can also present in front of a mirror if you want to see if you have like unusual facial expressions or just sort of how you look.
So journal club. So have you guys done formal journal clubs in pharmacy school? Okay. I know I had never done one before, so I think. So I just included mine just so. Do you guys know this format for journal clubs? Okay, so this can be a very quick, we're not obviously going to talk about my journal club, but unless you guys really want to. But always include the title, the year it was published, and in what journal it was published in, the funding. I always like to give background, and then any other previous trials that might have led to this trial. So a lot of your diabetes ones, there's obviously previous things that would lead to what the trial is. The objectives, you can just copy and paste those. Include the study design, the endpoints, study population, and I can always forward you guys this too if you want. The procedures, statistical analysis. I always like to keep this part very short and sweet because I'm not the best statistics person. And then just the results is where you kind of list everything. Some people end up copying the tables from the article, which I think is perfectly fine. I think the main thing with journal clubs and something that I've seen on rotation is always limit them to 2 pages, 1 page front and back. I know sometimes I've come and some people will have 5 pages. It just gets very wordy if it's longer. I always make mine first, so mine might be 1 or over 3 pages, and then as I'll resave it and then make the handout version, so that way it's not as wordy and I can things out.
I know Kristen definitely does this at the end, but always say your takeaway from the article and how is this going to impact your practice. Are you going to recommend, if this is a new medication, would you actually use it or would you recommend it to a provider? That's something you'll get asked at the end of every journal club.
or if it's about like a new drug, like I know we've had it like where the preceptors will be like, so if you were going to start your patient on this drug, what would you counsel them on, and stuff like that. So just being aware of the potential questions that you might get asked.
My favorite journal club question at the end is, so what? Like, I mean, so what are we going to do? Are we going to change what we're doing? Does this give us new information? Are we going to make new recommendations? Or did this just add to what we already know about and we're not going to change our practice?
Your conclusion is almost always going to be a little bit different than what they concluded in the article.
And so I just wanted to, this is just brief because we're going to go over APPE, working up a patient, but just in general, and I think Tyler and I have the same exact strategy for at least the first thing that we look at for a patient is, I think initially in pharmacy school, mine would be reverse. I'd go to notes and then like work my way up. But now in residency, I just go straight and click the medications tab because it's almost kind of like you're doing like a little like mystery guessing, like, all right, they're on these, 10 medications, what might they have? And then I'll move my way through, like, is it indicated? Is the dose correct? Is the strength correct? What's their renal function? What's their liver function? Is it a home med or something that was started new inpatient? And then if they're on an antibiotic, obviously looking at their micro results. So seeing if it's susceptible to something that's a little less broad, if they're on vancomycin or anything that needs to be monitored, following up on levels, was the level drawn correctly? Would we have done something differently? Labs, always, I think, just focusing on like their white blood cell count, red blood cell count, platelets, as well as just their general BMP and CBC. In terms of vitals, blood pressure, heart rate, respiratory rate, and temperature, knowing if the patient spiked the temperature, if they're no longer febrile. And then the last thing I'll click on is the notes, if I even get to it before rounds. So.
Yeah, and so when you start working on patients, you're going to have 1, 2, or 3 patients. So in that case, you're going to have a lot of time to dive deeper into each patient, go through more of the notes, look through more of the complete patient. So I would say you can use the strategy you can use. If you think like a SOAP note, you can go subjectively, objectively, like down the line. I would say we'll go more into depth with the next presentation.
Yeah.
But keeping the whole patient in mind is a really big thing. So what's going on overall with this patient? Do all their medications have an indication? Are they dosed appropriately for their renal function and other factors? Are big things. And then just as you get more comfortable, you start to think of more interventions you can make as a pharmacist.
And then the last slide I had was for end of rotation. So thank you notes. This can be either like a personally written thank you note. I guess it can be sent via email. I always think that personal thank you notes are a nicer touch. I know some people make, treats at the end of rotation. I was never one that made it. I'm not a very good baker, so I never made treats, but I know that your preceptors do, and I know being on the other side of things, I always get very excited when students bring in treats, but they are not required by any means. But I think just making sure that you express your gratitude to the preceptor. It's a lot of work to be a preceptor, and so just making sure that they know that you are very appreciative of all of their time. I always think it is super helpful to update your CV at the end of each rotation. And so this helps, especially if you're going to like mid-year or even applying for jobs, to not have to think back and be like, what did I do on this rotation? Did I do a presentation? Who did I present on? What day did I present? And stuff like that. So just going through and highlighting the big things that you did on that rotation. And then how to ask for letters of recommendation. I think that this is always kind of like an awkward. I always thought it was a little awkward to ask the preceptor, and a lot of my letters didn't come until my rotations from like September, October, and November, so they were kind of later in the year. So I think it goes back to what Tyler said at the beginning of rotation, being very open and upfront that you are planning to apply is something that is definitely reasonable. And I think Claire, like even saying up front, and I need 3 letters of recommendation from an inpatient clinical pharmacist, and so just letting them know, like at the beginning of rotation, that this is something that you might ask towards the end, would be very helpful. I don't know how you asked your people.
Well, and then the other advice I got, so during your final eval is a perfect time to ask for this. You need to have an understanding and a feel for how you think overall that you did. Not everything you're going to do is perfect, and not all your feedback is going to be positive. But know that you put appropriate effort in, and then you have a good relationship. And then I would ask I'm planning on applying for residency. Would you write me a positive letter of recommendation? And saying the word positive feels kind of weird, but being on the other side, people do write letters of recommendation that are not as positive as the candidate probably would have liked them to be. So I would definitely clarify that, or a strong letter of recommendation. And preceptors are not going to write you a positive or a strong letter if they don't feel that you're qualified for it. So I think that for the most part, everyone would be honest with that, and if they're able to do that for you.
Could also use the word favorable.
Favorable, yeah. However you want to word it, but you want it to be good.
And then once you do ask them to write your letter, it's always very important to keep them in the loop about I would always send them like my updated CV just so they can, obviously they're going to speak to me on rotation, but it's good for them to know me as a person and as a whole. So one lady I even had coffee with just so we could chat more on like a more personal level. And then just keeping them in the loop about your timeline. So I'm going to mid-year in like December. My goal is to have my letter submitted by XYZ date. These are all the programs I'm applying to. I need separate letters for each one. I want to use all the same letters for the same one. There's a lot of different strategies to do it. These are the deadlines for each program I'm applying to. I don't know, I like this program because XYZ, it'll help me meet these goals. So just, you can make like an Excel sheet, a Word document, or just a table, just so that way they know, oh, Kristen really likes this program because she went there for pharmacy school and that's for, like stuff like that. So.
Yeah, I mean, you should give them, I would say, at least a month's heads up on writing a letter. Because if you want it to be good, it's going to take some time on their part to do that.
Yeah. The other thing is to make sure if there are program-specific elements that need to be in the recommendation that you have provided that information to the preceptor. Because many sites, including the one for which I'm responsible, has a rubric, and we're grading looking for certain things in that rubric. And if it wasn't articulated to the reference writer, then you're just missing a whole bunch of points.
Any other feedback for asking for letters of recommendation? I feel like that's...
Realize that the whole rotation is a job interview.
Yeah. All right, do you guys have any questions about anything in general?
Can you send us these slides?
Yes, definitely. And then I'll have like another like a Word document that I'll send for APPE and what each like tab is what you can find under each one. That way you know exactly which ones to click to. So maybe I'll hold off and send both at the end on Friday. And then Tyler will follow up about that pocket guide thing, and I can include that in my email too. Does anyone in Richmond have any questions? Awesome. Well, thanks, guys.
All right, thank you, guys.